Today we will study about nephropathology. So we know we have a pair of kidneys, and these kidneys they are connected to the bladder by the ureter, and the bladder gives the output of the urine via urethra. And similarly we have this abdominal aorta coming, and it is becoming renal artery which is supplying to the kidney. And in kidneys we have nephrons as the functional unit, and these nephrons basically acts as to filter the blood so as to get rid of the waste material from the blood. So these nephrons, they are made up of a round structure which is called as glomerulus, and this glomerulus has a afferent arteriole which is coming into the glomerulus, and it is making capillaries over here and again exiting out as efferent arteriole. Here you can see in the cortical part, in the cortex, renal cortex, this nephron with the glomerulus part of the nephron is lying, whereas in the medulla part of the kidney, the glomerulus, the Bowman's capsule, is changing into the proximal convoluted tubule, which is continuing as the loop of Henle, and then the distal convoluted tubule, and from the distal convoluted tubule the urine is going into the collecting duct, and from the collecting duct it is going into the ureter. Nephropathy or the kidney diseases. So these kidney diseases, they causes certain conditions in the body which are called as acute kidney injury, or previously it was called as acute kidney failure, but now the term has been replaced by acute kidney injury. So whenever there is reduction in the function of the kidney, that is excretion of the waste products, whenever there is reduction in that for 7 days, we call that condition as acute kidney injury, or AKI. We will study about this in detail. Second is chronic kidney disease. When the kidney injury or the kidney diseases, they become prolonged at least for more than 3 weeks and for 3 months, then they become chronic kidney diseases. That the condition is called as chronic kidney disease. And another one is renal failure or kidney failure, which is now termed as end stage renal disease, ESRD, where there is complete loss of kidney function and the person requires hemodialysis or the artificial interventions. Some important terminologies regarding to the nephropathies. First is what is normal urine output. So 0.5 to 1.5 ml per kg per hour is the normal urine output. You can see here for adult it is the urine flow rate should be greater than 0.5, for child it is greater than equal to 1 ml, and for neonate it is greater than equal to 2 ml per kg per hour. Oliguria is less. Olig means less, urea means urine. So there is less urine output when the urine output is less than 300 ml per meter square, means surface area of the body. We are talking about surface area. So 300 ml for 1 meter square in 24 hours if the urine output is less than that. For children it is less than 0.5 ml per kg, and for infants less than 1 ml per kg. Right? Usually it is considered that if a person is urinating less than 500 ml per day, if an adult is excreting less than 500 ml per day of urine, then it is considered as oliguria. Whereas anuria means very less urine output, less than 100 ml per day. If somebody is excreting urine, then it is called as anuria. Whereas polyuria is when the urine output is high, greater than equal to 3 liters per day in adults and 2 liters per day in children. Nocturia is nocturia means noct means night. At night, if the frequency of urination, if the person is going to urinate very much at night time, then it is called as nocturia. Next is frequency. Some other terminology which you should be aware of are frequency, urgency, hesitancy, incontinence. Frequency is the number of times at the rate or the rate at which a person micturates. Micturates means passes the urine, with or without increase in volume. That means a person can increase the rate of micturition with the increase in volume or without the increase in volume. For example, in diabetes, the volume of the urine is increased. It is more than 2500 ml per day. So with that increased volume, the person passes urine at more number of times. Whereas in certain conditions, for example, urinary tract infections, the urine volume is not increased. It is in the normal volume, but then also person will void the urine at many time. So that is frequency. Frequency is increased micturition rate, either with increase in volume or without increase in volume. Second is urgency. What is urgency? Urgency is sudden desire to void the urine. A person cannot hold his urine and he has to suddenly pass the urine, otherwise it will leak out. For example, in the cases of neurogenic bladder, where the nervous supply to the bladder is not proper, or the nervous supply is overexcited, or urinary tract infections, the person has to urgently go to the urine, go to the urine passing. Then hesitancy. Hesitancy is delay in the initiation of micturition, when the person is having a delay to start the micturition. The person keep on waiting in the washroom for the urine to come out. That is called as hesitancy. The urine is hesitant to come out. Example, benign prostate hypertrophy in males, where the prostate gland increases in size and it compresses the ureter, compresses the urethra, and which causes hesitancy. Incontinence. Incontinence is involuntary leakage of urine. So this incontinence is of many types. First is stress incontinence. When the urethral pressure, the pressure over the urethra or pressure over the bladder is more. For example, if somebody is carrying a baby, if somebody is pregnant, so that can lead to, pregnant women can lead to have an incontinence. The urine will leak out because of the bladder pressure. For example, coughing, for example, uterus prolapse, for example, sneezing, for example, lifting heavy objects, or for example, pressing over the bladder when bladder is full. Urge incontinence. Urge incontinence means when the person has sudden desire to void and the person can no longer hold and the urine leaks out. So that is called as urge incontinence. It is mostly due to the muscles overactivity, the muscles of the bladder which are overactive. That is, the detrusor muscle of the bladder is overactive. Example, in elderly, in the setting of urinary tract infections, or in some neurological diseases, for example, stroke. So then next is overflow incontinence. Overflow means when the bladder is full, the urine leaks out automatically without the patient realizing it. So that is because the detrusor muscles are weak and the bladder is distended. Example, in cases of benign prostate hypertrophy. Then next terminology is nocturnal enuresis or bedwetting. So bedwetting, we all know, bedwetting is wetting the bed with the urine. So intermittent nocturnal incontinence means at the night time the patient do the bedwetting. Then next is hematuria. Hematuria is blood in the urine. We will talk about this hematuria in later on slides, or we will talk about this hematuria in a separate slide. Right? So hematuria is blood in the urine, when the urine is mixed with blood and it comes out with the color of red. Then proteinuria and lipiduria. These proteinuria and lipiduria, whenever the urine consists of more proteins than the normal and more lipids than the normal, then the urine becomes frothy. It becomes a froth. There is froth coming out of the urine. So then how do we assess the renal functions? How do we assess that the kidney is all right? So there are few blood tests and there are few urine tests. So the red here represents the test of the blood. We take the blood sample, and the yellow here represents the urine sample. We take the urine and we test it for few things. So important blood tests which represents renal functions are: number 1, serum urea or blood urea nitrogen, one and the same thing. Then serum creatinine, then the ratio of blood urea nitrogen to serum creatinine, then serum uric acid, and some serum electrolytes like sodium, potassium, chlorine, and bicarbonates. Whereas urine tests, first is urinalysis, the microscopic and the macroscopic ones. Then the urine proteins, urine albumins, urine creatinine, then the albumin to creatinine ratio. We take the urine albumin and the urine creatinine. values and we divide them. Then glomerular filtration rate, which tells us about the filtration function of the glomerulus. Then urine glucose, urine sodium, potassium, calcium, phosphorus, urine ketones, urine bilirubin and urobilinogen, urine cortisol, urine culture, urine osmolality and urine HCG. We will talk about these tests in a separate slide. So let us come to the nephropathies. Nephropathies are diseases of the kidney. So I have summarized these nephropathies in 8 types of nephropathies. Number 1, the congenital diseases. Number 2, the glomerulus or the Bowman capsules with the efferent and efferent arterioles. That glomerular is having some disease, glomerular diseases. Next is the tubulo interstitial diseases. The tubules, that is the distal convoluted tubule and the proximal convoluted tubule, the loop of Henle is having some disease, or the cells in between these structures, the cells in between DCT and PCT, they are having some diseases. So that is interstitial cells are having some diseases. So tubulo interstitial diseases. Then urinary tract infections. This is another group of kidney diseases. There are urinary tract obstructions, when the tract is having some obstruction, for example kidney stones, urolithiasis. Then renal cyst, there is cyst formation in the kidney. Then vascular disease, the renal blood vascular, the vascular supply is having some diseases, the blood vessels are having some diseases. Then renal tumors. So these 8 categories we are going to study in detail. Number 1 is congenital kidney diseases. These are probably not in your syllabus, but you should know. For example, agenesis, when there are no kidneys at all, so the fetus won't survive. Then ectopic kidneys, when the kidney is not in their place, they are somewhere else, you can see it here. Or hypoplasia, one kidney is not developed. Or horseshoe shaped kidney, when the kidneys are joined with each other. So these are some of the congenital diseases. Next is glomerular diseases. So we know that this is glomerulus. This glomerulus is also called as renal corpuscle, and this Bowman's capsule is lined with, little anatomy, is lined with podocytes here, which gives support. These podocytes give support to the capillaries, the glomerular capillaries. The efferent arteriole is coming and it is giving out capillaries here. So these capillaries are supported by a basement membrane, and below the basement membrane we have podocytes. Here is the basement membrane, you can see the purple structure here, and these small cells here are podocytes. They have feet-like processes. And in between the capillaries there are these mesangial cells. You can see as mesangium intraglomerular cells. These mesangial cells are also important because there are many pathologies which takes place in these mesangial cells. You can see mesangial cells here also, the green color also, they are also mesangial cells, but they are extraglomerular mesangial cells. And now here is the PCT. So the basic filtration takes place here. The blood comes here and it filters these glomerular capillaries have pores in them. They are specialized capillaries from where the waste material, according to the size, passes out from them into the glomerulus, and from the glomerulus it goes into the PCT. So glomerular disease is also called as glomerulopathies. The diseases of the glomerulus are called as glomerulopathies. So these can be result of primary kidney disease. That means the disease inside the kidney the disease has originated inside the kidney. For example, IgA nephropathies, which is also called as Berger disease, or the kidney diseases which are secondary in origin. That means the diseases of the other system, they have got into the kidney. For example, diabetes, which is a multi-system disease. Because of the diabetes, the kidney is affected, so the disease is a secondary kidney disease. So glomerulopathies can arise because of primary kidney disease, for example Berger disease, or secondary kidney disease, for example diabetes, which is called as diabetic nephropathy, or lupus nephritis, which is as a result of systemic lupus erythematosus, which is a systemic disease, autoimmune disease. So because of that autoimmune disease, when the kidneys are affected by that autoimmune disease, we call that condition as lupus nephritis. Most of the etiologies for these glomerular diseases or glomerulopathies are idiopathic. There are no explained cause. The presentation of some glomerulopathies are asymptomatic. right? Most of them, they are asymptomatic, that means they have no symptoms at all, and during the investigations only accidentally someone finds that they have a glomerulopathies. Glomerulonephritis is another term in which these glomerulopathies have inflammation in the glomerular capillaries, which can be because of the primary disease or secondary disease. So glomerulonephritis is another term where there is inflammation in the glomerular capillaries. This glomerulonephritis can be acute or chronic, right? It can be acute glomerulonephritis AGN or chronic glomerulonephritis CGN. When this acute glomerulonephritis is progressive in nature, that means it progresses and the renal function deteriorates more and the person lands up into acute kidney failure or acute kidney injury, then it is called as rapidly progressing glomerulonephritis. Chronic glomerulonephritis is a slow progressive glomerular disease which ultimately with time leads to kidney failure or end stage renal disease, ESRD. So once again, the glomerular diseases are many. For example, we know about IgA nephropathy, Berger disease, diabetic nephropathy. These are all glomerulopathies, right? And glomerulopathies which have inflammation in them are specially called as glomerulonephritis. So here I have labeled the causes for these glomerular diseases. So we know most of them, they are idiopathic, no cause, whereas few of them, they are because of the genetic mutations. For example, FSGS, focal segmental glomerulosclerosis, or MPGN, membranoproliferative glomerulonephritis. Some infections can also lead to glomerular diseases. For example, PSGN, post-streptococcal glomerular nephritis. That means after a streptococcal infection, mostly in the throat region, can lead to a glomerular disease. Just as similar to that of the acute rheumatic fever. If you remember acute rheumatic fever, it was also a post sequelae to throat infection of streptococcal. So similarly, the throat infection can also lead to the autoimmune condition which is post streptococcal glomerulonephritis. Bacterial endocarditis, the bacterial infection of the endocardium, can also lead to glomerulonephritis. Then malaria in some of the conditions can lead to glomerular diseases, glomerulopathies. Fungal infections, HBV infections, hepatitis B infection, hepatitis C infections, or HIV infections can also lead to glomerular diseases. Toxin exposure, if somebody is taking toxin, for example lithium in certain drugs, or NSAIDs, the non-steroidal anti-inflammatory drugs, for example diclofenac, the antibiotics, for example ciprofloxacin, these leads to glomerular diseases in few patients or if taken in excess. Then autoimmunity, some of the diseases, they are autoimmune. For example, Berger disease, IgA nephropathy, in which there is immunoglobulin A involvement. There is because of the antigen antibody complex or because of the complement system, the person develops autoimmune reactions which leads to glomerulopathies. Lupus nephritis, this is systemic autoimmune diseases which leads to kidney involvement also. Atherosclerosis of the glomerular capillaries, they also leads to glomerular diseases. Hypertension, diabetes mellitus, SLE, and thromboembolisms of the vessels, blood vessels, they also lead to glomerular diseases. So what are the common clinical features for glomerular diseases? If somebody is suffering with a glomerular disease, for example acute glomerulonephritis, or let us say PSGN, post-streptococcal glomerulonephritis, then generally it is asymptomatic and it corrects on its own. But however, in some of the patients, symptoms can appear. For example, periorbital edema in the morning, right? Periorbital means around the eye. So around the eye, in the orbit there is loose connective tissue, and that loose connective tissue is prone to get edema first. So periorbital or edema in the morning is usually the clinical feature. Peripheral edema in the evening, whereas the edema over the legs, it is mostly evident in the evenings. Xanthelasmas, because of the lipid metabolism derangements, because of the kidney diseases, there will be lipid metabolism derangements which will lead to Xanthell's mass. Then Muir-K bands, that is white bands in the fingernails. Malar rash, if the person is suffering with systemic lupus erythematosus, there will be a butterfly kind of rash which is called as malar rash over the face. Palpable purpura, there will be redness over the skin which is palpable. Frothy urine, the urine will be frothy because of the lipiduria and the proteinuria. Hematuria, it could be the glomerular disease could result in blood in the urine. Signs, other signs are oliguria and hypertension. The person could be suffering with oliguria if it is progressing, and hypertension also. The other symptoms could be fever, nosebleed, hemoptysis, because there will be derangement of the or leaking of the fibrinogen from the blood into the urine. So there will be hemoptysis, nose bleeding, the bleeding disorders, fatigue, hair loss, weight loss, right? And if this glomerular diseases they progress, it results into AKI, right? The rapidly progressing glomerulonephritis RPGN leads to AKI. Then there will be the signs and symptoms of AKI. We will talk about this AKI in the end. So what are the investigations? Always remember proteinuria and hematuria. If they are there, then they are strong indicators of glomerular diseases. Most of the times these glomerular diseases are undetected because they are asymptomatic and they correct on their own, and the person hardly realizes that they have gone into the glomerular disease. Kidney is a very, very strong structure. It takes care of itself just like the liver. Especially if there are RBCs or there are RBC casts. We will talk about this when we will talk about investigations in a different slide. So this dysmorphic RBCs, that means when the glomerulus start leaking the RBCs into the PCT, which normally should not happen, then because this RBC passes through these narrow tubules, it becomes dysmorphic. It loses its normal shape, the convex shape it loses, and it becomes abnormal shaped like a star shaped. So that is called a dysmorphic RBC. And many RBCs, they join together and they form casts. Casts are, they take the structure of the tubules. So if RBC casts or dysmorphic RBCs are present, then it is a strong suggestion. They give us strong indicators for glomerular diseases. So now these glomerular diseases are broadly classified under two syndromes, which are nephrotic syndrome and nephritic syndrome. And these are common questions in the exam. What is nephrotic syndrome or what is nephritic syndrome? So nephrotic syndrome, basically nephrotic syndrome, the difference between nephrotic and nephritic syndrome is basically at the level of the excretion of protein in the urine. If the excretion of protein in the urine is greater than 3 grams per day, then the condition is called as nephrotic. If it is less than 3 grams per day, then it is called as nephritic. More or less other symptoms are same. For example, hypertension, the patient develops hypertension in both syndromes. Hypercholesterolemia, hyperlipidemia, more or less in both syndromes. Especially nephritic syndromes are concerned or are having hematuria with dysmorphic RBCs and RBC casts. So if hematuria is present with proteinuria, with moderate proteinuria, we label that as nephritic syndrome, and these nephritic syndromes are mostly associated with inflammation with nephritis. Whereas the nephrotic syndromes are mostly concerned with the chronic diseases, for example diabetic nephropathy, right? Other examples are amyloidosis, which is a systemic disease, minimal change disease, MCD, mostly found in children, focal segmental glomerulosclerosis, or membrane glomerulonephropathies, right? Membranoproliferative and membranous glomerulonephritis. So these are few examples of in which nephrotic syndrome is seen. Once again, the difference between nephrotic and nephritic syndrome is basically in the proteins and in hematuria. The proteins are lost more in the nephrotic syndrome, whereas hematuria is seen more in the nephritic syndrome. So what happens when this nephrotic or nephritic syndromes are there in the body? So this is the pathophysiology. The glomerular damage, it leads to increased permeability of the glomerular basement membrane. If you remember the purple color membrane, in the previous photo. So there is increased permeability of the glomerular basement membrane, which leads to the leaking of protein, which should not be there in a normal kidney. So the leaking of protein leads to the proteinuria. The increase in quantity of protein in the urine is called as proteinuria, which is the pathological is greater than 3.5 grams per day. If it is coming massively greater than 3.5 grams per day, right, we collect the urine for complete 24 hours from the patient, and we find the total number of proteins lost in that urine, in 24-hour urine. If it is greater than 3.5 gram per day, it leads to hypoalbuminemia, because the major protein in the urine is albumin. So if protein is lost, that means more albumin is lost, and the blood will now having less albumin. Hypo means less, albumin means albumin protein, emia means blood. So there is less albumin in the blood. So now the serum albumin levels goes less than 3 grams per 100 ml. The normal is up to 3.5 grams per ml. So it goes less than 3 grams, and we know that this albumin protein is the major protein which makes the oncotic pressure of the blood vessels. So the plasma oncotic pressure is now less because these proteins are less, which will lead to decreased plasma volume, because this oncotic pressure is responsible for maintaining the blood pressure inside the capillaries. So there is less plasma volume. Less plasma volume will lead to the less glomerular filtration rate, right? The rate at which the glomeruli filters, the normal is from 90 to 130 ml per minute. So which is less. If it becomes less, it leads to the activation of the RAS system and the aldosterone secretion. The aldosterone secretion leads to the sodium and water retention. You remember the RAS system, renin, angiotensin, aldosterone system. So whenever there is low glomerular filtration, right, the blood supply to the kidney, whenever it decreases, it leads to the activation of the renin. It leads to the release of renin from the JGA cells, and from that renin will cause the angiotensin 1 to convert into angiotensin 2, and the angiotensin 2 will lead to the release of aldosterone, and this aldosterone will lead to the sodium and water retention in the kidney, so thereby increasing the blood volume, the plasma volume. Now the blood does not have albumin protein, so the blood cannot hold the water inside the blood vessel, so it starts leaking out into the tissues, which leads to edema. So this is the pathophysiology of edema. So it will lead to edema. The glomerular damage will lead to edema. Also the hyperlipidemia, because of the lipid metabolism disorder, because of the glomerular damage, there will be lipiduria in the urine. So after glomerular diseases, let us move on to the tubulo interstitial diseases, the diseases of the PCT, DCT and the interstitial cells. So these tubulo interstitial diseases are clinically, they are a collection of disorders just like glomerular diseases, which share tubular and interstitial injury, right? These are divided generally into acute and chronic nephritis and acute tubular necrosis. So first is acute tubule interstitial nephritis, right? Acute tubulo interstitial nephritis, acronym is ATIN, right? So this ATIN, it takes place whenever there is injury to the PCT, DCT and the interstitial cell. Nephritis means inflammation, whenever there is inflammation in the kidney, which leads to the damage to PCT, DCT and the interstitial cells. The common causes are antibiotics. The antibiotics, they at higher doses, or certain people are allergic to certain antibiotics, which leads to interstitial nephritis, which ultimately, if progressive, it also leads to acute kidney injury or acute kidney failure. Certain NSAIDs for prolonged time leads to acute tubular interstitial nephritis. Diuretics, for example, people take diuretics to lower their blood pressure or to lower the edema in their body, right? Diuretic drugs like spironolactone anticonvulsant drugs, infections, certain bacterial viral infections, or certain autoimmune conditions like SLE, they leads to acute tubulo-interstitial nephritis. Then chronic tubulo-interstitial nephritis, this tubulo-interstitial nephritis or tubulo-interstitial disorder can be chronic also. So for example, sickle cell disease, people who are suffering with sickle cell disease, they might end up having chronic tubulo-interstitial nephritis. Lithium, if certain drugs, especially antipsychotic drugs, they contain lithium, heavy metals like lead, cadmium, and for the matter of fact mercury, right, they also leads to chronic tubulo-interstitial nephritis. Antineoplastic drugs means anti-cancer drugs, immunosuppressant drugs like cyclosporin, obstructive uropathies, right, that means if there is obstruction, if there is, let us say, stone inside the ureter which leads to obstruction, that can lead to chronic tubulo-interstitial disease, nephritis. Then third and the most dangerous aspect of tubulo-interstitial disease is acute tubular necrosis, ATN. This acute tubular necrosis is the necrosis, that means the death of the tubules, which ultimately leads to the loss of the nephron. So this acute tubular necrosis is generally irreversible and it leads to permanent kidney damage, whereas these acute and chronic tubulo-interstitial disorders, they are generally reversible. So diarrhea and vomiting. Diarrhea and vomiting leads to the blood volume loss. The blood volume loss will leads to the decreased perfusion, hypoperfusion of the kidneys, which leads to the tubular necrosis because of the ischemia of the tubules. The tubules will not get enough blood supply and it will lead to ischemia, which will lead to necrosis. So diuretics, right, if diuretics again lead to hypovolemia, again leads to ischemia of the tubules, leading to acute tubular necrosis. Then congestive cardiac failure. In congestive cardiac failure also the blood volume is less because the fluid transfers from the blood vessels to the interstitial spaces. So in congestive cardiac failure also there is less pumping of the blood through the blood vessels, which leads to the ischemic injury, ultimately necrosis of the tubules. Snake bite and other toxins, they also lead to tubular necrosis. So acute tubulo-interstitial nephritis is an inflammatory condition where inflammation and the edema of the renal interstitium and the tubules develops in days to months, right? Most of the time it is allergic. It is allergic drug reaction. That means allergies to certain drugs. For example, most commonly sulfur drugs are having allergies to certain people, to many people. So these allergic drug reactions leads to acute tubulo-interstitial nephritis. Also from certain infections, patients develop acute tubulo-interstitial nephritis and it is reversible. The damage to the kidney is reversible. These ATIN can cause acute kidney injury, and especially in cases where it is severe or the treatment is not proper, or the offending drug, for example the allergic drug, is not discontinued, and it can also lead to permanent injury and chronic kidney disease. But this acute tubulo-interstitial nephritis hardly progresses into chronic kidney disease. Symptoms and signs may be non-specific and they are often absent unless symptoms and signs of renal failure develop, right? So most of the time it goes unnoticed because of asymptomatic condition. However, if somebody is having an allergic drug reaction in them, then there are certain signs and symptoms which they appear. For example, if somebody is allergic to, say, let us say ciprofloxacin, the common antibiotic, then the person will be having fever, urticarial rash, that means skin rash, urticarial type of rash, eosinophilia, right, in their body, in the blood also and in the urine also, right, and abdominal pain, weight loss, bilateral renal enlargement can also be seen, right. Peripheral edema, hypertension are less common. Polyuria and nocturia are also common, right. So these are the few conditions which can appear in acute tubulo-interstitial nephritis. So always remember, allergic drug reactions leads to ATIN. Eosinophilia, leukocyturia, that means more amount of WBCs in the urine will be there. Eosinophilia, there will be more eosinophils in the urine also and in the blood also. Oliguric renal failure, The person will be having oliguria, which is characteristic of renal failure. In renal failure, the first thing that comes is oliguria. Serum creatinine level rises because the kidney is not able to filter creatinine, which is a waste product from the degradation of the muscles. Proteinuria will be there, right? And renal biopsy will show interstitial edema under the microscope, right? So the microscopic test will show the renal biopsy will show the interstitial edema as well, right? So once again, the allergic drug reaction, most of the allergic drug reactions, or the most important cause for acute tubulointerstitial nephritis is allergic drug reactions. Then there is chronic tubulointerstitial nephritis, which results from a chronic tubular injury, chronic tubular insult, right, which is gradual, which leads to fibrosis in the tubulointerstitial compartments, and tubular atrophy dysfunctions, which leads to chronic tubulointerstitial nephritis, CTIN. Causes are mostly immunologically mediated disorders, for example SLE, infections, obstructive nephropathies, for example nephrolithiasis, the kidney stones, drugs, some certain drugs they causes chronic tubulointerstitial when taken for a long time, right? So generally the CTIN are labeled as these analgesic nephropathies when because of certain analgesic drugs, for example paracetamol, if it causes tubulointerstitial nephritis, analgesic nephropathies. Metabolic nephropathies, if somebody is having a metabolic disease, for example diabetes. Heavy metal nephropathy, if somebody has taken heavy metals, for example mercury, for a longer time and his tubulointerstitial structures have damaged, so heavy metal nephropathies. Reflux nephropathies, right? Reflux means because of the kidney stones and all. Symptoms and signs are generally absent in chronic tubulointerstitial nephritis unless kidney failure develops. So it goes unnoticed until and unless patient starts developing renal failure. Next is urinary tract infections. So urinary tract infections are the infections of the urinary tract, which could be bacterial, viral, fungal. Right here you can see, in this picture you can see, if the infection is in the kidney, it is called as pyelonephritis. If it is in the ureter, it is called as infection of the ureter. If it is in the bladder, it is called as cystitis. If it is in the urethra, it is called as urethritis. So infection can dwell at many places. Generally the infection which starts from the urethra, if untreated or if the person is on the immunosuppressive drugs, then it goes to the bladder and causes cystitis, and then it ascends up and causes pyelonephritis. Kidney is very rarely affected by the infections. Generally the urethra and the bladder are affected. So what is UTI? The microbiologically UTI is whenever the organisms in the midstream sample of urine, midstream means when we take the sample, we take the midstream of the urine, right? Not the front and not the end of the stream of urine. So when the midstream urine contains 10 raised to the power 5 organisms, more than 10 raised to the power 5 organisms, bacteria and all in them, then we consider that as UTI. It is more common in female. UTIs are more common in female because in females the urethra has close proximity to the anus. In males, most of the times UTIs are absent, but if there are UTIs, mostly they are associated with some structural deformity. For example, if a male is suffering with kidney stones or prostate problems, then they are having more risk of developing UTIs, otherwise not. UTIs can be divided into lower tract infections and upper tract infections. Upper tract means when the kidney and the ureters are involved. Lower tract means when the bladder and the urethra are involved. So the urethra is infected with some bacteria, colonization, and that colonization leads to the penetration of bacteria into the bladder, and from the bladder it ascends through the ureter and goes to the kidney and causing pyelonephritis. If pyelonephritis is untreated, it might cause acute kidney injury, or it might even cause chronic kidney diseases, but it is highly unlikely. It highly unlikely means the pyelonephritis hardly causes acute kidney injury. What are the causes? The responsible organisms, the bacteria are E. coli. 75% of the time it is E. coli. Proteus, mirabilis, Pseudomonas, Streptococci, Staphylococci, Chlamydia, Nisrae. These are the sexually transmitted diseases, organisms which cause sexually transmitted diseases. They can also cause these UTIs. And some viruses like herpes simplex virus or some fungal infections. Now the sign and symptoms according to the place, right, they also little bit having little difference. For example, if urethra is involved, then person mostly will be having burning sensation in the urination, and a discharge, a pus discharge, or some reddish discharge from the urethra. If bladder is involved, which is called as cystitis, then mostly the person is having lower abdominal discomfort, frequent painful urination, blood in the urine, and pelvic pressure. The person will feel that the lower abdomen is having pain and pressure. However, if kidney is involved, then the person will be having a flank pain. That means the vertebral angle will be having, the renal angle or the renovertebral site will be having a pain, high fever, shaking and chills. Very important. There will be chills. The person will be having chills. If a person is having chills with burning micturition and flank pain, that is highly suggestive of acute pyelonephritis. Nausea, vomiting also occurs. Clinical features. The common clinical features are dysuria, painful urination, increased frequency, increased urgency, renal angle tenderness, flank pain, right? Pain at the site of the kidney, loin pain, lower abdominal pain, tenderness, low back pain, hematuria, fever, chills, rigors, one and the same thing. Complicated UTI are, this is one more term, complicated UTI. Now some UTIs are labeled as complicated UTI, which requires prolonged treatment. That is treatment for 30 days, treatment for 15 days. The antibiotics are given for 30 days or 15 days. These complicated UTIs occurs in patients who are already catheterized. They are having catheters inside them, for example, in the setting of ambulatory patients. Then anatomical problems, like somebody is having anatomical abnormality in their ureter or urethra or bladder. Functional abnormalities, for example, somebody is having functional trouble in the bladder or some neurogenic bladder. Stones, obstructions, immunosuppression, if somebody is on immunosuppressive drugs or somebody is suffering with HIV, diabetes, or they need prolonged antibiotics. So if a male gets an UTI, that is considered as a complicated UTI, because the length of urethra is very long in male and it is very difficult to flush out the infection. So males, they rarely get the UTI, but if they get UTI, then it is treated as a complicated UTI. Children, small children and pregnant females are also treated as complicated UTI, plus patients who are admitted and catheterized, or patients who have anatomical or functional abnormalities, for example stones, obstructions, immunosuppressions, they are treated as complicated UTIs. Then the investigations. So there will be increased WBCs in the urine sample. Greater than 5 WBC cells are seen if seen in one high power field, right? That means under the microscope, at one place, if you see more than 5 WBCs, then it is increased WBCs, which is called as pyuria. Pyuria means increased pus in the urine. So pyuria or leukocyturia. Urine nitrites are certain substances in the urine which are present only when there is bacterial invasion of a urinary tract, right? Because these bacteria, they convert nitrates into nitrites. So urine nitrates are only found if the urinary tract is infected with certain bacteria, especially gram-negative bacteria. So this urine nitrate test becomes positive. Urine culture of midstream urine, it becomes positive and it shows sensitivity also. Urine acid-fast bacilli, if the urinary tract is infected with mycobacterium. So next category of disease is urinary tract obstructions. We will not go into this because this is the syllabus for 4th year. So urinary tract infection, for example, most common stones, or there are strictures. You can see the ureters have become with no space, right? There is no space in the ureter. So uretropelvic stricture. Stenosis, again the ureter have become stenosed. There are certain fibrous bands. Or polycystic kidney, because of the polycystic kidney there is urinary tract obstructions, right? Here also you can see urethral stenosis, right? The urethra is becoming stenosed. Urethral sphincter has developed some spasms. so the urethral sphincter is not allowing the urine to pass. So these are urinary tract obstructions. Prostrate, you can see prostrate in the outside this urethra in the males only. So if prostrate has become enlarged, then it compresses the urethra, leading to urinary tract obstructions. So what are the causes? Within the lumen means within the ureter or within the urethra. For example, stones within the ureter or within the urethra, they can lead to urinary tract obstructions. Inflammations, clots, the renal tumors within the wall of urinary tract. For example, urethral stricture, the wall of the urethra is having some trouble. Pelviureteric neuromuscular dysfunction, congenital bladder neck obstructions, right? The bladder neck is congenitally obstructed. Neuropathic bladder, or pressure from outside, for example from prostrate, for example benign prostate hypertrophy, pregnancy, tumors, or phimosis condition in a condition called as phimosis, which leads to obstruction of the urinary tract. Next is renal cyst. So sometimes the kidney develops renal cyst, and the most important disorder in this is polycystic kidney disease, which is an autosomal dominant disorder, which is a genetic disorder. And because of the genetic disorder, the person develops polycysts in the kidney, and in later stages this polycystic kidney disease leads to acute kidney injuries, which ultimately leads to end stage renal disease, which is renal failure. The cortex medulla is filled with large number of cysts and then slowly compresses the surrounding normal tissues, and patient develops progressive renal failure and large kidneys. Clinical features: the kidneys becomes large, they are palpable, there is abdominal discomfort, there is hematuria, there is more UTIs, stones, progressive renal failures and all. Next is renal vascular disease. Also, we will also not study this in detail. For example, renal artery stenosis, right? The artery becomes stenosed, the artery becomes less in aperture, less in size, which leads to the reduced blood flow, leading to damage, right? Some of the vascular diseases are renal artery stenosis, acute renal infarction. You can see it here. If the renal arteries, they are blocked due to atherosclerosis, you can see here, or blocked due to some embolism, thromboembolism, then it leads to renal infarction, just like myocardial infarction, which leads to kidney damage and ultimately leads to kidney failure. Other conditions like hemolytic uremic syndrome, thrombocytopenic purpura, TTP, systemic sclerosis, they also leads to the renal vascular problems. Then renal tumors, we can well imagine the tumors of the renal, the kidneys, the benign tumors and the malignant tumors as well, they causes kidney failures. So the topic starts with kidney failure. We will study about this kidney failure in the next video, right?